Good afternoon. I'm Sabine Dupont, Senior Policy and Advocacy Consultant at IDF Europe, and I wish to welcome you all to this IDF Europe webinar to mark the launch of our publication on delivering value through innovation in diabetes care delivery. And indeed, promoting and fostering the adoption of innovation is central to IDF Europe's mission of improving the quality of life and the health outcomes of people living with diabetes. And in particular, it's really close to our heart to make sure that people living with diabetes are being listened to. And perhaps more importantly than listened to, are being heard regarding their needs, but also regarding the way in which they want to avail themselves of innovation. And we now have a raft of tools, technologies, approaches at our disposal that can help prevent and better manage diabetes and diabetes-related complications like we've never had before. And it's truly mind-blowing, and it covers a number of different aspects. On the technology side, there have, of course, been huge developments in insulin delivery and glucose monitoring systems. And what is truly remarkable is that most of these were driven by people living with diabetes themselves, and notably the Open APS and the We're Not Waiting movement amongst others. And we really cannot emphasize enough how instrumental those movements have been, not only in driving the innovation itself, but also in ensuring or driving the diabetes ecosystem to do better. And that's the medtech companies, it's the regulators, national governments, etc. So beyond those technological tools themselves, there has also been a real acceleration over the past years in the use and development of different types of digital tools and platforms, and also in the development of more person-centered and personalized care. And again, this was partly driven by COVID-19, but as well as making those the diabetes management better, those tools and platforms and approaches have actually acknowledged and recognized the fact that people living with diabetes should be and are equal partners in their care. And if you accept that, then it follows that people living with diabetes need to be educated and empowered in order to make the right decisions regarding their treatment options, but also in managing their condition better. And there has been a lot of innovation in that respect as well. And there's a real need, because we know that people living with type 2 diabetes, for example, may only see their healthcare professionals perhaps 3 or 4 times a year, perhaps 10 minutes at a time. And whilst it might be a little bit more frequent for people living with type 1, for example, it still only represents a tiny proportion of time when you consider that diabetes requires 24/7 management. So these have been fabulous advances, and we've got a lot of things at our disposal. What we have not cracked yet is how to ensure that innovation is adopted at scale by national health system, and ensuring that actually the innovation is accessible to all those that need it. Because another thing that COVID-19 has taught us is that there are huge inequalities in access to care and in health outcomes across Europe. And that's both between European countries, but also within countries themselves. That is quite simply unacceptable and unconscionable. So in this centenary of the discovery of insulin, we hope that the publication, and I think that we will put the link to the publication in the chat. So we hope that the publication and the webinar will really help bring to light some of the innovations that we think have tremendous potential to make the lives of people living with diabetes better and to improve their care, but also to guide national health system in their investment decisions. And we really think that investment in innovation should be seen as an opportunity and not as a cost. It really has the opportunity to save and improve lives. And I think that there's a real momentum and opportunity at this point in time. Of course, because of the centenary of the discovery of insulin, but also because COVID-19 has really brought to the fore the need for governments to tackle the challenge of non-communicable diseases such as diabetes. And we can see that this is now coming through a little bit in the minds of policymakers in initiatives such as at the EU level, the Healthier Together initiative. And we really urge the diabetes community to engage with those opportunities out there. So without further ado, I will give the floor to the webinar moderator, Mark Dupont, who is a healthcare consultant and a fervent patient advocate. And he will introduce himself and the rest of the speakers. So thank you. And again, I hope that you enjoyed the webinar. Mark?
Thank you very much indeed. So I'm a Scotsman, so I'm going to try and speak slowly. English is supposed to be my first language, but I know it's not the first language for everybody, and I do appreciate you all speaking in English, so thank you for that. I also want to thank IDF for asking a patient to moderate this session, and we'll hear from other patients, and I think it's really important that we see IDF and other organizations, you know, living not just the dream of patient engagement and nothing about us without us, but actually involving us not just in consultation, but co-creation of these documents and this webinar and everything else. So as Sabine has said, I'm a patient with type 2 diabetes for the last 10 years, thankfully currently in remission, but I'm also an ex-pharmacist and I am a dreaded management consultant who helps organizations with, interestingly enough, patient engagement and digital health. And we have a wonderful panel, and I'm going to hand over to the panel just to tell us who they are, their role and which company they're from. And then I'm going to hand last of all over to Nebojša, who's going to do a presentation, and then we'll get into the questions and answers. And I've got a few questions for the panel, but by all means, please, 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 as the audience, ask your questions. They're equally, if not even more important than the questions we've prepared. So without further ado, I'm going to hand over to our first panelist to introduce ourselves, to Elena.
Hello, I'm Elena Fratellin. I'm a mother of a type 1 young man. I'm from Italy. I'm also a volunteer in the local association, which I'm the president of the association, but it's a federation of association of my local area. And I'm also vice president at national level of different federations. And I'm active tribute to the Inter-Society Study Group on Technology and Diabetes. So hello to everyone, and thank you very much to IDF for inviting me.
Thank you very much for joining us. Ciao.
So I think I'm next. So greetings from Portugal. My name is João Raposo. I'm the medical director of APDP, the Portuguese Diabetes Association. That's a patient association with a different model from most of the other patient associations all around the world, because we have in the same place, the association, the largest outpatient clinic for people with diabetes with an integrated practice unit. We have a research center, a training facility. So we are much concerned with the diabetes practice in Portugal and around the world. And as that, it's a pleasure to be here and discussing such an important topic as the innovation in diabetes care. So very nice to be with you.
Thank you very much indeed. Partha.
So hi, my name is Partha Kar. I'm a consultant in diabetes. I work in the UK. I've also got roles in a national setting where I'm the National Specialty Advisor. I look into technology, whether it's type 1 or type 2, education, etc. So that's my role at the present moment. And as ever, as others have said, an absolute delight to be invited to this forum and hopefully can contribute something as well. So we shall see.
Thank you very much indeed. Samuel.
Hello, everyone. Thank you for having me today. My name is Samuel Al-Chevalier. I'm the director of the diabetes program at Alligator Healthcare. I've been working in home healthcare for the last 9 years in Canada, the Nordic countries, and France, which allowed me to see a variety of healthcare systems and models. And one brief word about Air Liquide, the organization I work for. We're a global leader in the provision of medical gases to hospitals. And we've been providing solution in home healthcare for the last 30 years. We provide, we're present in 35 countries and have 15,000 employees in healthcare. And we provide support to 1.8 million patients, including 85,000 people with diabetes. Extremely pleased to be with you today and looking forward to the discussions.
Soufiane, would you like to go next?
Sure. Absolutely. Hi, thank you very much for inviting me here. I'm Soufiane Hussain. I'm a diabetologist at Guy's and St Thomas's, which is part of King's Health Partners and one of the largest centres for diabetes technology and type 1 diabetes in the UK. I'm an honorary senior clinical lecturer at King's College London with an interest in diabetes tech and advanced therapies in diabetes, especially type 1, and a person with type 1 diabetes for the last 30 years as well. So thank you very much for inviting me and hope to make a positive contribution.
And last but not least, Tim, I'm sorry, I was saying Soufiane and realized I was also on mute. So I'm still learning how to use this after 2 years.
Yeah, hello everybody. This is Tim Schmidt from the French Ministry of Health. I'm working as the advisor for the General Directorate for Health and mostly on European affairs and specifically on the EU for Health program. And as I will later explain, there's some very interesting initiatives going on cardiovascular diseases and specifically diabetes. So thanks for having me.
Thank you for coming, and very much last but not least, and I might say to our other panelists, if they're okay to put their camera off, to let Nebojsa have the limelight while he does his presentation, and then we can all come back on. It allows us to do our cup of tea and you know, fix our hair and all the rest of it. So please, Nebojsa, over to you for some introductory remarks. Thank you.
Thank you very much. I hope you hear me. My name is Nebojsa Lalic. I'm from Belgrade, Serbia, a physician, internist, and an endocrinologist by training, and at the same time for 30 years in diabetes practice and diabetes advocacy. At present, I'm chair-elect of IDF Europe. And should I, being as in these presentations, the last panelist, should I then continue with the presentation or?
Yes, please go ahead.
Okay. And then I will just allow me to share my slides. I hope you can see my slides.
Yes, very well, thank you.
Okay, fine. So this webinar we dedicated to the delivery of care. In fact, in an attempt to increasing the quality of delivering value through innovation in diabetes care delivery. And and in order to define the priorities of the diabetes community, which was the task that we just were engaged on for some time. So please take my presentation as an introduction to what the other people will say, and at the same time you will have in the chat the whole publication, which is almost which is now ready to be distributed. In this context, I don't think that I should remind all of you or any of you about what the burden of diabetes is. It is definitely the health burden. It is a gross financial burden, and finally, it's a psychological burden. But on the other hand, we should remind ourselves then 1 in 11 people will very soon have diabetes, or 67 million in 2030, which is a considerable figure. But this is not the point of our webinar, or at least it is a background. But we are really trying to work on how to tackle the burden of diabetes. And among that, we defined in our documents these 5 approaches, or 5 tracks, if you wish, with the primary prevention of type 2 diabetes, the screening and early action, improved diabetes management, which can be considered as secondary prevention, and then, which is maybe the focus of this webinar, integrated patient-oriented care models and value-based care, together with reducing health outcomes inequalities, which are present even among the European countries. And I will try to very briefly go one by one. Regarding primary prevention, it is definitely that we are advocating for national diabetes prevention plans, or at least observatories, which is important for being aware of what are the situations, and designing the early interventions in order to prevent type 2 diabetes. Then screening, in this context, screening and early action is something which is maybe sometimes rather complicated to organize, but screening at risk population and immediate action can reduce the number of undiagnosed people, because about 30% of the type 2 diabetes, people with type 2 diabetes are undiagnosed. And in this context, the screening of the diabetes itself can help lowering the risk of complications. So in this context, screening has a very important place in these activities. Improved diabetes management means that an adequate access to lifestyle interventions, medicines, technologies, and care should be provided to any community, to people with diabetes to the same extent, and that is something which should be strongly educated for. Also, but in this context, the primary care as the system, healthcare system, which is very close to the people with diabetes, should be strengthened as the very powerful tool for organizing a modern diabetes care, and at the same time to ensure the patient, or the empowerment of the people with diabetes, to improve self-management and health and digital literacy, because illiteracy in this area has become and has been detected as an important problem. Finally, we came to the maybe major point of this webinar, and this is integrated patient care-centered models and value-based care, which means that the treatment of diabetes is a very complex one, and it should not be just prescribed without integration, coordination, and putting the patient in the center of it. And for years, many care models and value-based care were developed, although not many attention has been drawn to it. At present time, review and redesign of national models of care is really a need in order to ensure integrated multidisciplinary care and to ensure that care is centered around the patient, which and with this context, the implementation of the registries, the patient registry, but also the specific registries and electronic health record is something that should be definitely backed in any country, and try to obtain some type of equal European level for this purpose, which finally all that would lead, but in final instances, in reducing health outcomes inequalities. And we are sorry to detect that there are inequalities, and we should set up an EU-wide common digitalization and data framework, or at least the network of the observatories that would follow up what is the outcome of all these procedures, and we should be able to use population data to ensure care and support for people with the greatest needs. And this type of, let's say, integration effort or networking effort, which is integrated into the two last items, is in fact the major topic of this webinar. Thank you very much.
Thank you very much indeed for that. That was lovely, and it's nice to see a picture's worth 1,000 words. I'm always a big advocate of using PowerPoint to its best advantage and using it for pictures, and so thank you for so beautifully accompanying that. So I think I want to sort of open with a question, really, just to make sure that we're all on the same page. And I think it's important about how we define innovation. And I just wanted to, open up to the panel. Within the publication itself, we define it as novel behaviors, protocols, technologies, and ways of funding and organizing care delivery that are not yet delivered at European level, but that have the potential to improve health outcomes, optimize the use of resources, and enhance patient experience and quality of life. Wow, that is pretty comprehensive. I will start my video. I have done my hair. There we go. So I'm happy to be here. Sorry about that. So I wanted to open up to the panel just to see what you as an individual and or your organizations use for the definition of innovation, please. So who wants to kick that off? Samuel.
I can start off if that's helpful. So I think what is key in this definition is the emphasis made on patient outcomes and patient experience. And there are, I guess, related measures, but I come from a company, an organization that's built on years of experience in home healthcare, in proximity with patients, in the intimacy of their homes. And based on this experience, we're convinced that measuring these outcomes, understanding the care pathway in its entirety, and overall engaging into this value-based healthcare approach that we've heard in the initial introduction will make the difference. That's really what I take away from this definition.
Okay.
I've got to stop doing this. I might just leave it on. I've got a dog outside that's making noise, so I'm trying to keep muting. Partha, I was asking you, how do we define innovation in the NHS?
I mean, how do we define it and how it's actually used are two different things altogether. The definition really of innovation should be, the way I see it is adoption of more modern times, which makes self-management better. That's what innovation should be about, right? And it's For example, is Netflix an innovation? Of course it's an innovation, right? It's made our life simpler about what movies you want to see and watch and all that sort of stuff. So I think innovation definition should be that, is adaptation to modern times to make self-management more in line with changes in society. That's what innovation should be.
And I like the idea that you're talking about innovation, not just being technically driven, but also being about attitudinal and health psychology and service provision. I think as a patient, and I'm sure we'll get into this and it's in the report, I think sometimes innovation doesn't necessarily need to be, as we said, shiny, but just changing thinking. And in my own experience of care over the last 10 years, I've seen a slow shift towards a more person-centered or approach rather than just, oh, your islets of Langerhans or your pancreas is broken. I think diabetes, I'm not sure if it leads the way in terms of specialties, but I do think there is something about diabetologists being that little bit more patient and person-centered. Any other bit that wants to jump in on their definition of innovation?
I want perhaps just to add that, because I think your last comment was quite appropriate, Mark, because when speaking about innovation, I think most of us or most people in the world will think about technology, platforms, devices, when the main stakeholders in this process will be always people. And from that part of people, we have the healthcare providers, and we have now a huge definition of the healthcare providers that are taking part of this process. And we have the people living with diabetes and their caregivers and all the lay people taking care of diabetes. So I think most of the innovation that we have added now, it's really that level of interaction between the people living with the condition and the people taking care of them or helping them to take care of themselves. That's the real innovation. And then the best use of other tools to support this process of care. And I think that's the new model, the new horizon for innovation. And that's it. We cannot forget always the people involved. We are always thinking about jumping for the technology, for the next step. And I think Partha was speaking about the use of other platforms for other things in our life. And we are always jumping for the next one because there's always a new thing coming to the market. And for taking care of diabetes, of course, it's good to jump for the next best step, but not forgetting the basics. And we are not investing the most of it in the basics.
I think we'll get into that in a moment, but talking to Partha about this fascination with the invention side and the shiny side of the innovation curve, and really only innovation works. No one talks about a fax machine anymore. No one talks about a toaster or a kettle. For innovation to be truly ubiquitous, it needs to become invisible. While we continue to talk about it, it's not. I don't think we've rolled it out, and it's lovely to see that focus, as we say, on the patient as well. Elena, did you want to add a little bit around the definition, and anyone else before we move on?
Yeah, when Elizabeth invited me to this webinar, I thought that innovation, I would talk about technology because I'm a techie person and I like technology very much. And my son is using an open source and, all the stuff. But actually looking at the numbers, I mean, so many people, 1 in 11 live with diabetes. So many people don't achieve a good blood glucose control. And we know that the costs, at least in Italy, the most part of the costs are in complications. And we know that in Italy, at least 91% of people living with diabetes are type 2. So I changed my mind about, because I'm often focused on type 1, but actually we have to lower the numbers of diabetes and of course of type 2. So probably we have to communicate differently to these people, and we have to empower in a different way these people, because we have for a long time spoken about empowering, but actually we didn't succeed. Here at a local level, we succeeded in empowering people when we decided to train tutors, people with diabetes or caregivers, train them how to speak to people with diabetes, what to say, what not to say, and how to bring their experience and how to coach them. And at that moment, we used those volunteers at camps, educational camps, and we really found out it was a very good thing we could do to help people overcome their fear to be judged because they were people with diabetes. There's a lot of stigma. Some of them didn't even want to show they were with diabetes. Some of them were hidden. They did everything in the bathroom, check their blood and things like that. They would never do it in front of other people. And at the end of the camp, maybe they were feeling very, very well because they could show. So innovation could be also training tutors, training peer to support other peers. For example, I think.
Yeah, I'm going to give you a quick story. The great thing about being the moderator is you can tell your own stories. Very quickly, I have a friend of mine, Sheila McCorkindale, who won't mind me stealing this story. Parth, I'm sure will know her, was a GP up here in Manchester. And she'd done a motivational interviewing course, and she was all excited about, you know, talking to me as a dummy patient, as a dumb patient possibly, but as a dummy patient, just going through her motivational interviewing training. She said, let's kid on, you're my patient, and come in. So I sat down and she said, hello, nice to see you today. And I said, oh, Dr. McCorkindale, nice to see you. And she said, oh, please call me Sheila. And I said, no, I want to call you Dr. McCorkindale. So that was, again, me. And I was just playing a little bit difficult, but that was part of her training to sort of reduce the barrier potentially between professionals and patients, although we could argue patients are professionals too. Long story short, she said to me, so Mark, you know, we talked a little bit about diabetes. She said, what are your life goals? And I said, I don't want to talk about my life goals. I just want you to give me a prescription for metformin. And the idea, and she said, why did you do that? I said, because I want to show you that although you as a clinician have done motivational interviewing training and you've got into a new approach and thinking about lifestyle and the bigger patient and the person behind the disease, if we've not prepared patients for that different conversation, we might just default back to well, I just see you as a GP as a supply function, and please don't ask me a difficult question like, what are my life goals? Because that's quite difficult if I've not been prepared for it. So I think, Elena, on your point about training, we need to make sure that that training is equally for patients and to manage their different expectations potentially of a consultation. Just on that, unless anybody's got anything to add on the definition.
Sorry, if I may,
please.
Just add one word. You most probably did not read the publication, but at the very beginning there was an attempt to define innovation, and it was said, if I may read it in a rather bureaucratic way, it is the innovation was defined for the purpose of this report as novel behaviors. It was defined rather broadly as novel behaviors, protocols, technologies, and the ways of funding and organizing care delivery that are not yet delivered at the European-wide scale. So we try to put all these things that you mentioned together.
Yeah, and wasn't suggesting they were excluded, and I think it's great. And I haven't read the full report. I have read the executive summary, but I will try to do so over the weekend. No promises. But just on that topic, and thank you for that lovely segue into it, I'm just interested in the panel of ideas of these sort of innovative tools and technologies or approaches that you can share with us. What practical insights can we get from the panel to move this wonderful publication and its examples to examples that you as panelists have? Who'd like to share some stuff? Elena's talked a little bit about some stuff. Who else? Sufyan, you want to talk a little bit about some of the stuff you're doing?
Yeah, no, happy to. I think just going back a little bit, of course, as all of you rightly mentioned, that, you know, the innovation aspect isn't just around the technology side, although, you know, of course, that's a big area that has mushroomed in the last 20 years, and healthcare in general has been very conservative in how it adopts changes. You know, it's had a very traditional model of responding to trials that can take a number of years in the drug sector, and that's part of the reason why there's been a bit of slow adoption when it comes to things and new practices. But I agree with the point that, you know, this is very much about outcomes for the individual and what matters to them when it comes to innovation, and that encompasses social factors, commissioning as well, attitudinal changes. I mean, I grew up in a third world country, and I remember, you know, one of the biggest innovations was getting a steady stream of electricity supply for one of the communal fridges that went to a small village where insulin could be kept. and that was innovation for that particular place. So I think it's drawing context into it. So going back to your particular question of examples, I think first and foremost, I think we're trying to see what the problem is, what the problems are at the moment. And one of the big problems for pretty much every healthcare system is the burden, is the fact that you have a growing burden in diabetes. Type 1, type 2, that's the case. You don't have enough healthcare professionals. You're dealing with, obviously, a lot more early onset of conditions and more complex environments and how people have to live with these conditions. So how do you enable better outcomes to be achieved, knowing that there's going to be this gap and shortage of resources? And then when it comes to this, then you start thinking, well, what will allow us to deliver things at scale in a patient-centered manner with the sort of response that individuals will need? And that's where you look and you realize that mHealth and e-tools have their potential and utility, and the technology comes in. So certainly in type 1 diabetes, when coming to this particular examples, the co-creation chapter is one that's been something that I've been working very closely with. Some people have already echoed, open source systems, where people have designed their own technologies. It's, I think, obviously a very far end of the spectrum when you start thinking about the whole differences in range of people's technical and health literacy in diabetes. But I think it just shows an example of when people can come together and use their intellect and their creative capital to deliver a particular tool that people can derive benefit from at a fairly large scale. So that's one example. And I guess the thinking is, how could that be translated to the wider masses? And now thinking about type 2 even, how can that be translated? And how can we use the citizen science and creative capital to do that? So sorry if I've gone in a bit of a long-winded way.
No, I think that's wonderful. And I like the creative capital. I'm trying to keep an eye on Q&A and chat. And somebody put in the chat when we were talking about the definition of innovation, value beyond economy. So I think that's a really key point you've touched on in terms of the broader impact and the social impact. Samuel, just to take the point that Sufyan was making in terms and your introduction about a global company with global reach and looking not just at diabetes, but at different therapy areas, where have you found, that innovation in healthcare delivery perhaps landing most successfully?
Yeah, I mean, in my view, the approach is with the most potential when it comes to innovation is the one, and we talked a little bit about this, but the ones that place the patient at the center of the solution, then would provide personalized solution powered by data, because now it makes the difference, and with both digital and human interaction. And lastly, solutions that involve all stakeholders. And I'm sure we'll have more and more time to talk about this. But just to come back on the two first point, on patient centricity, what we've seen over the last decades is that when visiting patients in their homes, we've learned one thing is that treatment success depends on a person's capability and motivation. And as it was a little bit said before, we can deploy any sort of innovation, any sort of technologies. If we don't have that patient-centric approach, it won't work. So we need to understand patient needs, their behaviors, their pain points, and co-create the solution with them. I truly believe in this people empowerment approach, and I think Sabine made a reference earlier to the "we're not waiting" movement. If you listen, 1 minute to Dana Lewis, you have it, right? Like they're doing it. They want to be at the center of it, and we need to involve them in it. And on my second point, the personalized solution. Again, like innovative technologies are not accessible and convenient for all without human support, without their clinical team support, without their home care provider support in certain countries. And so we believe that this right balance between digital and human relationship is the key to improve outcomes. And maybe lastly, we're now within Air Liquide leveraging more and more therapy relevant data to create insightful solutions. So not just static, but the elements that provide insight to patients and that enable this personalization. And we're deploying platforms to communicate remotely with people with diabetes. We see that thanks to these technologies, we're able to adjust channels, frequency of support, and again, remote monitoring or in-person visits with educational support, technical support sometime, but we really build these solutions leveraging data around the patient and with them.
I'm still here. I'm just unmuting as I'm trying to catch up with I'm finding now we've got a WhatsApp channel, I've got a Q&A, I've got this, and I've got my gardener outside. So this is the wonders of working from home nowadays. It's like, you don't know quite what's going to happen. Just to hand over to some of our patient reps, from the point of view of patient innovation, from the point of view of what you're seeing as successful. Elena, you touched on it a little bit in your introduction, but what are you seeing in Italy and Portugal and broader afield in terms of, not necessarily the technology stuff, but, that innovation being embraced at your country and regional levels?
Okay, let's say that innovation is also technology, which I think is very important, but I wouldn't focus only on technology because it's not for many people. So I would like to speak to something that interest more people. And one problem is, for example, the healthcare delivery system. We have been told for years that it should be patient-centered, should be focused on outcomes and, sustainable and things like that. But then people now have to go from one specialist to another one, have to figure out when to book his blood exams, his vision check, or cardio electrocardiogram and things like that, and to have everything ready for next visit. Well, we should not wait for people do all this on their own. There should be an application or something that takes care of people booking their exams, booking their visits in time. And if it would be maybe in the same place or in the same day, that would be great, because sometimes people have to manage their blood glucose, their diabetes, and also, which is already a big deal, but also they have to manage all bureaucracy and things that, we could make them work much better. And then another thing is, I would like to say is data. We don't use enough data we have. We have tons of data for type 1, for example, for CGMs and, and things like that. And we don't use them properly because we want to use them to understand how much of innovative drugs or, technology, or even for maybe walking group support or peer support group, how much they worked. So if we have a database where we can insert all the data, all the informations about this person, which drugs use, which technology, which kind of education gets, which kind of peer support uses, then maybe we can also extract data and find out what worked and what did not work. So this, because we have to implement an healthcare which is sustainable, but if we don't know which intervention are good and work well and which did not, maybe we cannot do it properly. So there's a lot to do in innovation and in communication too, because we have to find a way to communicate to people, to get to them. For example, we found it out that doing things together was much better than talking to people. So we started making up events like skiing events, mountain bike events, tennis events, even eating events together. And people found out they could enjoy life, enjoy activities, enjoy friends, and manage well because they understood how to do it from their friends, their peers that were managing and enjoying life the same. So that's kind of communication, not verbal communication, but it's important too, I think.
Thank you. No, you want to say something?
Yes, please. So if I may add something to the discussion, and it's a great discussion. So when dealing with these innovation concepts, I think we are still not going to the part of the healthcare delivery models that's also in this document, because we are still trying to fit the care process of chronic conditions as diabetes in a more classical, old-fashioned model of delivering healthcare. And so, as Elena was mentioning, we are still splitting the care of people living with diabetes in different primary care, different hospital levels, different specialists, now with different models of access to technology. And even if we enjoyed so much those buzzwords of patient-centered, people-centered, integrated care, but in reality, people living with this condition don't feel they live in an integrated care process. They don't feel they live in a person-centered approach, because actually they have to adapt to the system and not the other way around. And that reflects on the outcomes. We are always discussing the outcomes, and now we are moving to those PROMs and PREMs that are clearly important in this process. But still, we are not achieving the best PROMs and PREMs because we are not adapting the healthcare delivery model. We are not discussing how to fund the healthcare for this new system. So it's almost impossible to move from that classical system to new models if we don't discuss that. And of course, that's so important. When I made my introduction, I said that I was working in the APDP, and I said it's still a different model of outpatient clinic. It was designed 96 years ago as what we call now integrated practice unit. So it says every person living with diabetes can go there and they have all the access to all the levels of care they need as an ambulatory care, all the different medical specialties, all the dietitian, nutrition, everything is there in the same place. So it's people living with diabetes go to one place and they have all their needs immediately taken care for. And that's still the concept that's impossible to see in most of the places in Europe. And then we are still not discussing how to put the healthcare services in a more proximity to the people living with diabetes. We are still here in Portugal pushing to have at the community level to have groups of people living with diabetes to support themselves, trying those kinds of peer support, and we can now do that either technologically or face-to-face, but still not using enough of those resources, and not discussing if the introduction of technology is really putting people in working closely or promoting inequalities in the system, putting people who don't have access to technology or countries that don't have access to technology in a poorer condition than other countries. And so we should also discuss this part of inequalities in the system.
Yeah, which I think, and Partha, I want to bring you in. I think on I know you've got a big issue and quite rightly around, equality and stuff. I mean, we've touched a little bit on, standard innovation, if there's such thing, now beginning to talk about not just incremental, but truly transformative innovation. I mean, some stories maybe from your own experience. I mean, I know you've done some stuff in the NHS and beyond in terms of the adoption side, but also reaching the seldom heard groups as well. Do you want to share some insights around that, please?
So I think there are two major things with that. I mean, number one is there's an issue with the way the system is set up. So if you are better off, you will have more time to attend those X, Y, and Z clinic appointments, and thereby you are skewed your access. And then there is the underlying issue, which we don't talk about much, but it is enough, is our own biases on ethnicity, etc. They all kick into gear. Now, if you look at, so what we want to do is, so if you want to challenge those, one is things need to happen at scale. So if you look at what's happened with, let's say, if you see the example of difference that we have in the UK of access to, let's just take insulin pumps and then compare it with Freestyle Libre, right? There's a fundamental difference between the two. One has got a massive deprivation and ethnicity gap, the other one doesn't. And the reason for that, the second, is that most of it was done at scale. So you need to move out. So if you're building a system whereby you have to go through a few clicks to get the technology. Well, if you are worried about how to, pay for your heating bill and you're worried about putting food on the table, you don't have time to go through those few clicks to get the technology, which ironically takes away the people who need it the most. So what we are going to do is we're going to put some money behind that to actually see, because nobody quite knows what intervention works. There's a lot of theory as to how do you cross the gap. So we're going to invest a little bit of money, try out some different systems. And it's not just about ethnicity, it's about reaching out to the deprived population and see whether we can sort of close that gap in access to any technology, any innovation. So, whether that's providing internet, whether that's providing readers, working with the companies to make sure that it's not just on your smartphone, all of those are on the table. So we'll see where we go with that.
Thank you for that. That sounds good. Any other panelists want to throw in some ideas of where they've sort of, before we move on to some of the challenges, any other, substantial innovative changes that they want to share with us?
I just would maybe make an introduction to the challenges, and if that's okay for everybody, and add maybe a more like bigger picture when it comes to national and European stakeholders on that issue. I would say there are two challenges that I would identify currently. The one is really when it comes to diabetes as a topic. I think a lot of attention was given on COVID and transmissible diseases. We've seen that during we have to see that on the European level, of course, health remains on the EU level remains a national and member state competency, and we have only like a supporting role for the EU, but we moved a lot forward in the last 2 years and responding to COVID. But I guess the big challenge on this area is that diabetes and generally non-transmissible diseases are rather on the backseat. We saw that with the revision of the legislation on the ECDC, which is the European Center on Disease Control, which is kind of the European major institution that compares data on situations, on diseases all around Europe. So it's a very essential tool for policymakers to make advice decisions. And so we really improved this mandate. During crisis, we did a huge work on European countries to reform it and to give it more money and capacity to do also when it comes to system and digitalization. But its only mandate remains on transmissible diseases, and all what's non-transmissible diseases, diabetes, it has no mandate yet. So I guess that's a challenge that we see. That we have to use that momentum that we have with COVID and European coordination to also put a specific focus on diabetes and generally on non-transmissible diseases. And I guess that's also what maybe is positive is what we're going to talk about later on maybe is that there is a common and shared strategy, which is Healthier Together, which is an interesting approach to say we have to have a common strategy when it comes to tackle non-communicable diseases in Europe and specifically diabetes. So this is on the way. And when I look at challenges, it's still that, of course, we have that common strategy, but we have to look at how we can implement it on a member state level. There's independence, of course, and every member state has its own system. So it's not always obvious to have a common European approach and then make sure that every national health system implements it in a common strategy. But maybe later on we can go more in detail on that.
Yeah, and I'm going to go over to Samuel just to warn him a little bit. I think you've touched on a great point, which is looking outside one country system and thinking about mass regional adoption. I mean, what experience, Samuel, have you had of maybe some of the barriers where it's worked in one country, but they won't take that information, or the particular regulatory authority wants to see a trial in that country as opposed to taking data from elsewhere? What challenges have you seen of that vision that Tom has painted a little bit of more joined up across Europe? Not that we're part of Europe anymore at the UK, but don't get me started on that.
No, thank you for the question, and actually I'm gonna maybe relate my answer to the few points that Joe was making earlier, which you were really right on, is because the solutions we're deploying are fairly new and with a significant amount of technology in it, the payment models are not always shaped to enable deployment at scale. So makes a situation country per country where we need to have that discussion with every single payer, looking at what exists today, how we can inscribe ourselves within maybe some buckets that exist, but also working with them to expand on the side some additional bricks that need to be there for the entire solution to work. And that's why we try, and I'm sure many organizations in the field try as well, is to work hand in hand with public bodies to ensure their participation from the start in the solution design. So we don't come up with a solution and then wonder how it's going to fit in the system. And on the other hand, and that's also something you mentioned, Charles, we advocate for this more coordinated and collaborative approach to diabetes care. And this, again, we've seen in every single country where we're trying to implement this solution. We're trying to have this discussion around value-based healthcare. We've talked about that, really alarming number of 75% of related costs come from complication of diabetes. And this, in my mind, comes directly from the gaps in the care pathway. And we believe that this more coordinated, targeted care will enable us to tackle this challenge.
Yeah, no, I think it's key points. And Joe, I think you wanted to pick up on a couple of points. I'm gonna hand over as well after that, if I may, Partha, to you, just to talk a little bit about, you said, we are investing in areas, and I just wonder what's the investment case for that, and how do we justify some of that? As we know, with innovation, it's always about, can we afford it, et cetera, et cetera. But first, Joe, I know you wanted to.
Just two comments on something that Tim has mentioned on our European response to the COVID pandemic, and just emphasizing the difference between the response to a pandemic as COVID and a different response that we have as a European region to diabetes by itself. So we have been advertising or doing our best to say that diabetes is a terrible disease, putting all the huge burden of the disease, most of the parliaments, governments everywhere. And even so, we were never able to mobilize the resources that were mobilized for this pandemic. And this is really important because this is the focus why we are dealing in such a different way to different diseases. It means that even when we say diabetes causes a huge burden to society, to economy, to the global development system, it means that we are not really perceiving diabetes as this dreadful disease. And so we should do more about this perceived value of diabetes in our society, because really it's not about numbers, it's about something else that we are not able to discuss and find and fight. The other concept, just the other comment, was about the value-based healthcare. And that's quite a magnificent concept, but so difficult to implement, especially in such a complex disease as diabetes. So it works perfectly for very specific diseases, procedures, as we all know. And I think we also should start to say at some point that for diabetes, even if it's not so easy to integrate that concept for a complex disease that goes from birth to death to multimorbid conditions to complications, but at some point we should define a new model of defining value-based healthcare for diabetes and starting simple and going to a complex pathway, because we are not doing that. And as that, we will be discussing for the next 10 years, value-based healthcare in diabetes, but not moving from that. So that's another challenge for us.
Yeah, I think it's absolutely key. We can get into definitions. I think as an ex-pharmacist, one of my big issues around value is when it comes to medicines or medical devices or digital health, before we even define any value, the patient has to be engaged and want to, as you say earlier, take the medicine, use the device, et cetera, et cetera. I sometimes find with digital health that we haven't really fully looked at people's hearts and heads. We tend to look at what's in their hands and think, oh, they've got a mobile, so let's solve it with a mobile phone, as opposed to, well, actually, let's understand their beliefs and their behaviors first, and then a mobile, something in their hands might be a device. Just Partha, on why we're on challenges and funding is always a challenge, or potentially always a challenge. How have you managed to use funding appropriately to help with the adoption of innovation, which is obviously a key coming up all the time?
So I think the first thing about funding is that funding is not impossible to get, but you need to have data and science to sort of go with that. So I think that is a very important part. So I'll give you a couple of examples of that. When we started the journey, for example, with Libra or CGM in pregnancy, there was a lot of criticism about all the criteria being very narrow. It was not the best technology, etc., etc. What I've always said to people is that when you're working in an environment where finances are crunched, you need to also show what's possible, and you also need to show what it actually achieves in a money environment. So you need to have the data. Data is key. Most systems don't have any data to make the case. So you're sitting there and you're trying to make the case from an emotive side, where you're saying, well, and then you have the debate, you say, well, it's shown X and Y in randomized controlled trials. Why can't we do it in a population? And that is a very difficult place to be in for a lot of policymakers, because when you try and extrapolate it, people then say, well, if you invest now, you save tons of money 10 years down the road. The problem with that plan is, I don't know how it works in other countries. In the UK, there is no 10-year plan. There's a plan till next March, right? So you are the concept of top loading an investment to gain benefits in the system is something that all health policymakers would want, but they don't have that luxury, right? So when you're trying to do innovation in this, if you gave us, all of us sitting here, a blank sheet, and you said, hey, listen, here is 100 million euros, you can spend whatever you want for the first 3 years, as long as you can show that you can stay within your budget. But I'm not telling you how much you invest every year. You do what you want to do. A lot of policymakers will take that. The problem is you can't do that. So to get around a lot of that, if you want innovation to kick into gear and be at rotation, our experience has been you need to start slow and then sort of expand it up. And I'll finally finish with this bit on that. This is well known in the innovation curve, and you will face this. The resistance is not only the money and the system. The resistance is also, for example, I would say it is well recognized innovation in the innovation world that clinicians can be a big barrier as well. So you'll always have that 4 groups of people. It doesn't matter what you started with, which will be, absolutely love this innovation, I'm straight away in. Then you have the second group, which is, oh, show us a bit more data. What does NICE say? What do they say? There'll be a third group of people who will just follow because everybody else is doing it. And then there'll always be a fourth group of people who will say, I don't like technology. I just don't like it. I don't like innovation. I want everybody to come and see me. And if they're not coming and seeing me, they will not get good care, right? And that's where you need the policy levers to say to them, that is not an acceptable way of doing it, because the science and the majority of the country are now doing it this way. You have to follow. So that's the way I would probably say you have to crack through it gradually. Data.
You remind me, Parth, of a great story. I was as a patient rep in a group once, full of clinicians and technologists and all the rest of it. And there was a gentleman there responsible for a very large area of England as what was then called the sort of PCT, Chief Accountable Officer, who was a GP. And he said, I'm a GP, I've got this background, we're looking after 650,000 people. He said, but I don't do digital. So I, as the patient, put my hand up, as you can sometimes do as the patient, and be a little bit more challenging. I said, can I challenge that statement? He said, of course. I said, do you use a stethoscope? And he said, yes. I said, would you think that a doctor who didn't use the stethoscope was perhaps negligent? He said, yes. I said, well, forgive me for saying this, but I think for somebody to say they don't do digital in today's day and age is perhaps, heading towards being a little bit like not being able to use a stethoscope as a medic. And he took a deep breath, as did everybody else in the room. And thankfully, he said, I hear where you're coming from and I accept the challenge. And maybe it's something that I should not boast about and something I should get some training for. So I think, as you've said, Partha, it's a lot of this stuff is attitudinal. It's not just about, the financing flows and the organizations and all the rest of it. Anybody on the panel wants to chip in with some challenges, or moving on to, as we've begun to do a little bit, some of the successful stuff? Anybody want to throw in some ideas of successful adoption of innovation? Elena.
Can I say just a few words on an innovative approach we had for inform people about the diabetes symptoms in a region in Emilia-Romagna years ago? We did a great job informing people, families, and whatever, which were the symptoms of type 1 in kids. And object was to avoid the DKA because we had a lot of DKA, severe DKA in the years before. And they communicated in different form in school, in game, in Boy Scout groups, by radio, TV, local newspaper, at the pediatrician offices and whatever. And they had they won the game because they really lowered the number of kids that were diagnosticated late. And so we didn't have many severe DKA. Actually, we didn't have any for a couple of years. And then they stopped this information campaign, and numbers stood very low for a while, and then they started growing again. So it means that communication, if you do it right and correctly, it can work. So you can communicate not only for the symptoms of type 1 for kids, which is important, but also on how to manage the disease, on how to recognize the symptoms for type 3. We remember when 1/3 of people do not know they have it. So maybe this could be an innovative approach of communication. We should use that. We know that information communication is important when we want to sell something. So why don't we use it properly for a disease like diabetes that spread all over?
Yeah, no, I think it's a key point, and I think we've touched on it, and just to express that. I'm on a diabetes webinar later talking very specifically about my experience, and comorbidities comes up because I ended up with depression for about 12 to 18 months, and it was quite moderate. I couldn't really function. And my question and perhaps issue would be to my healthcare professional is, had they perhaps mentioned the increased likelihood of a comorbidity associated with, getting diabetes, I might, and I can't promise anything, but I might have been able to take a few more steps, being more aware of it to prevent being incapacitated. So I think, as we say, people with long-term conditions, tend to not just have one disease. And I remember feeling myself being split into my endocrinologist, looking after obviously my pancreas, my hepatologist looking after my non-alcoholic fatty liver disease, and I stress as a Scotsman the non-alcoholic bit. And then I think thirdly, my psychiatrist looking after mental health. And the only integrator, despite talking about innovation and besides living in Salford in the north of England, which has a joined up record, only the real joined upness was coming from my wife, who at that time was caring for me. So we can talk about innovation, we can talk about adoption, but I think at the same time, as Partha and you've just said, it's about mindsets. And I think one of the questions coming in is, do we have the technology platform behind this to join some of these things up? Just aware of time, we've got about 15 minutes before some summing up as well. Any comments people want to make either on the challenges or the adoption before we sort of move into maybe a broader discussion about what stakeholders are missing and whom we need to bring in? And I can start taking, I've got a couple of questions from the panel, which not panelists, the attendees, which I can ask. So any points any panelists want to make, or shall I open it up to some questions?
I was just going to jump in and make a quick point. Just to re-emphasize some of the points made earlier, but actually just also bring to the equation that there isn't a one-size-fits-all. And certainly, I'll draw one extreme example. On a Monday, I do a very advanced diabetes technology clinic where I might see my closed-loop patients and the people I look after with type 1 who built their own systems. And on Tuesday, I go out to a GP practice in the depths of South London, one of the most poorest and deprived areas in the country, with a high ethnic proportion of people I look after. And majority of them will probably have a old Nokia mobile or may not have accessible access to even a smart device. And it's a very different demographic where English isn't the main way of consulting in that particular clinic. It's a very different, just highlighting it isn't one size fits all. And this is often comes into the mix when we're trying from a policy point of view or a system-based point of view, coming up with a one approach. So there's been a lot of heterogeneity in the system, which requires us to be aware of how we can deliver things to match what is required to the variety of people we're looking after. And ending this as a challenge really to industry, because certainly I work in, a lot of what I do is based around advanced therapies, technologies, But certainly when I look at the trials and look at the demographics of people who are brought into these trials and how therefore a lot of the devices that are used are designed, it doesn't really conform to the needs of those, what I talked about, who might be coming to my Tuesday clinic. So you have to think about how we do things differently. So just wanted to bring that to the equation here. And when we talk about technology, there's that risk that it can widen that disparity even further if we don't include the right people right at the start.
I think you've touched on a key point. I've been talking a little bit to some pharmaceutical companies about our patients' role in defining medicines. And a lot of it is often consultation as opposed to co-creation at that side. I think in devices and behavioral change and service interventions, we perhaps need to be even more, not just consulted and as end users and editors, but actually right at the beginning in terms of co-creation. And I know that in Portugal, there's a wonderful website that I always keep flagging called patient-innovation.com. And it's looking at how not just do patients consult and even co-create, but actually individually create technologies. So it's not just unmet clinical need or molecular need, but actually unmet patient need. And that to me, patient innovation is something really exciting. Again, in the NHS, forgive me, I'm British, but I think pre-COVID, we used to have something like every 36 hours, we had, I think, 1 million people touch the NHS. And I thought to myself, wow, can you imagine if a mere 1% of them came back with service improvements or innovations that they could suggest, not just their experience, important as that is, and not just recommending what we call the family and friends test, but actually saying, I noticed this flow in a operating theatre, in a clinic, in a community centre, and would it not be more efficient to do it this way? Or as one of my colleagues did, invent a device for patients with stoma. So I think there's really exciting times. I'm going to open up to some questions that have come in on the Q&A. One, I think, was a point very well made at the beginning, was saying, we're talking a lot about patients, but should we really be talking about people with diabetes? And I completely endorse that and attempted in my multi-channel way to say that IDF uses the term people with diabetes. So I think, that's something we touch on. But a question that came out, and I'd be interested in people's views, is what's the impact on innovation, either in a good way or in a not so good way, on healthcare professionals' time and their number? Do we have enough health and I'd say social care professionals? Is this innovation going to help them do their jobs better, more efficiently? Do we need less of them? Or do we still have a big gap? Does anybody want to touch on maybe the impact of innovation on health service personnel? That's an easy one. Joe.
It's not easy, but I'm much afraid of that point you mentioned, because in our contract within our national health system, we have consultations, and that means usually either face-to-face consultation or, especially after COVID, it means also phone calls, teleconsultation, something like that. But technology now made us other things available. We can spend more time dealing with people's data. Imagine on diabetes control, checking exams, checking things they have introduced in the platforms. And that's not part of the contract. So somehow we can say, well, this technology is saving us time for, I'm a doctor, for doctors, imagine, because as that, if people living with diabetes go to the consultation, most of the information will already be there, accessible. And instead of having 10, 12 minutes, I can do the consultations in 5 or 7 minutes. Imagine that. The logical part would be, okay, as that you'll have more time to check data, the platforms, technology, but that's not the case. Most governments will think, okay, as that you can see more people, more patients. And that's not good. We are forgetting that technology is not for that. It's for providing better quality time with people living with diabetes. And as that, recognizing all that work, all those different tasks that are new in the process. And still, that the healthcare delivery system that's not including these kind of tasks in the process.
Yeah, I think you've touched on a key point, and I think it brings me back a little bit to the point Tim was making about healthcare together and joining things up in different countries and different stakeholders. Again, my own experience of care is with the best will in the world, my clinicians in the same geography, in the same organization, don't necessarily talk to themselves as much, even with a shared record. Are we really, and forgive me, but are we really going to get to that point where I can go on holiday to Spain and to Portugal and to Greece and elsewhere and not need to worry about access to my data? I mean, is Tim, is that going to become a reality, or is that a fanciful wish? Sorry to be, talking.
Yeah, no, thank you for giving me the opportunity to intervene. I just would like to make also an invitation to our British friends that EU4Health is a program where we have non-EU member states like Norway, even Iceland. So your government, even though you left the European Union, you can be part of the program, and so to just open up that possibility, and that is not a political question, but I think a question of common sense when it comes to healthcare. And now to your question, what I find quite interesting in EU4Health is that it's a program that is based on, it's for the next 7 years. The program was increased 10 times. So we are at 5 billion euros for 22 to 27. So it's quite impressive. So similar to what we have in Horizon for research, which is there a long time further. And where is this money going? It's going to do things I think that really bring us forward. You talked about data. So we have the European Health Data Space, important initiative on digital. But this is going to be interconnected with also what's other objectives of EU4Health. It's putting an emphasis on prevention and health promotion. So at least 20% of EU budget is going to be earmarked on promotion and prevention. So notably on non-inclusive diseases and diabetes. As in comparison, and maybe my British colleagues can give us figures for Britain, but in EU, it's 2.8% currently of public health provider spending goes on prevention. So we're gonna raise that to 20%. And we will have a big focus on improving healthcare systems, working on health prevention and disease prevention, health promotion, and working on digital. And that whole thing goes together, of course, because if we want to have improved health resilience, we need common data, shared data, common indicators. So that's what I would like to introduce when it comes to EU4Health. If we have time, I would maybe introduce Healthcare Together as a specific initiative, or would you like to keep people to intervene?
No, please, just a quick, I think give us a quick overview. And if you've got a link you can manage to stick into the Q&A or into the chat, that would be really good. So that, I mean, I'm sure we can circulate it later, but always nice for people to have that link to follow up in, especially when there's dare I say, money available.
Of course, yeah. So as I said, so we have 3 types of dimensions. We have the program dimension, which is EU4Health, which runs up to 7 years, up to 2027, with the 5 billion euros to be spent by member states. We have the strategy level, which is the new EU4Health strategy, which is going to give us the objectives and the common goals. And we have the project level, and I would like to touch on that as well. We have 2 joint actions. These are these projects that's going to be implemented, and specifically we have 2 joint actions which start this year with about 130 million euros on health promotion and also on diabetes and cardiovascular diseases. And so Healthcare Together, what's so impressive about it, it's the first common European strategy on non-communicable diseases, and it's really interrelated to what we already have with cancer. With cancer, we have the European Beating Cancer Plan, which is very effective, which really makes European policymakers work together and health authorities. So we have Healthcare Together, which is going to be adopted. If you're interested, on the 22nd of June, the European Commissioner Kyriakides going to a huge press conference and going to get you through the specific points of Healthcare Together. In a nutshell, it's the idea to put the emphasis of health promotion, as I said, and it's based on 4 risk factors which are essential for cardiovascular disease and diabetes, which are alcohol and tobacco reduction, healthy diet, as well as sport activity. And we consider these are common risk factors that are on the basis of many of these diseases. And I think it's a very interesting initiative when it comes to our current topic, because it's really based on intervention. It's based on patient care ways, which are patient based and patient centered. And also community-based. So we were looking at community that are really risk and stronger risk of getting diabetes, for instance, interventions in schools, interventions in elderly homes and in immigration centers. So there's a community-based approach as well to it. And all this is all, of course, connected to the other initiatives as the European Health Data Space on data. So it's interconnected. And in my last 30 seconds, I'm going to introduce you to two of these joint actions, which are these concrete projects that are going to implement a new strategy. 130 million on the plate. There's one based on diabetes and cardiovascular diseases. So we're going to look at new screening models. So improve, for instance, diabetes screening all across the European Union with member states that work together in that joint action. It's about 50 million euros, which are going to be invested for that 3-year long project. It's about patient self-management tools. So we're going to implement and develop applications for patients to improve their self-management and quality of life as well. We're working on health literacy. We have for instance, in France, the Nutri-Score, and we're looking on other front of pack initiatives to improve and label better nutrition and their quality. And the second joint action that I would like to really quickly introduce, it's based more on these 4 common risk factors. And we are looking at what I said, nutrition programs in canteens and school settings and other community approaches. So these are good practices that are going to be shared among member states and going to be implemented in the next years. And of course, I'm looking forward to share also the link with you so you can look for further information on these joint actions that are going to be started. And of course, stakeholder implementation and implication is important. So NGOs, civil society are going to play an important role in implementing these actions.
Thank you so much. Now, I'm going to go around each of the panel members, and thank you for that, Tim, and just say to them, what would their sort of top tip be to participants around innovation? So a quick 30 seconds, if that's okay, before then handing over to Navoja to do a few wrap-up comments. So I'll simply do it in the order that I see you in my screen, so nothing personal. So I see João first, and then Elena, and then Partha on the top line, and then I'll come back to Samuel and to Sufyan. So João.
Okay, thank you. So in 30 seconds, so innovation for diabetes care. Well, I think first of all, we are acknowledging this document that IDF has produced, and I think that's the starting point, so people don't forget that we are just not discussing in just vain terms, but there's a document that can be thoroughly read and take most of the information there. And I think it's also our responsibility for the people that are watching also this webinar to push governments, to push parliaments to discuss this kind of concept. We are always in diabetes care discussing the cost of medication, the cost of technology, the cost of the healthcare, but actually we are just discussing the end line problem. We should be discussing again innovation as the new model for chronic condition, and using diabetes as the best example, because probably diabetes is the most complex disease. And so if we don't have the best outcomes for diabetes, it means that our health systems are not doing the right task. So that's the innovation we are missing. It's not a specific drug, it's not a specific technology, it's the design of the process that we are still missing.
Fantastic, thank you very much. We want more toasters and fax machines. Elena.
Oh, one of the innovations I'd like to see in the future is to start thinking not only about costs of diabetes, but also about investment in health. So when I talk to administrators that talk to me about costs of CGMs or pumps, I don't like that, because the real costs are complication-related costs. So we should get the data to demonstrate how much people's management get better using some tools like CGMs, but also like empowering somehow, and demonstrate which are investments and which are real costs. And this could be an innovative way to look at other costs of diabetes altogether. And another little thing is COVID has taught us to use telemedicine, to use different resources. Well, also for diabetes, we should implement interactive resources and different kind of resources we could use and people could use at their home and over again if they needed them.
Thank you very much, Partha, Samuel, and then Sufyan. 30 seconds each, and I'm going to hand over, just running out of time.
Yeah, I'll keep it short and simple, is that if you're going to do innovation, then two things. One is collect data, and lots of data to actually convince people that and you need to see innovation as just modernization. It's not something shiny, it's just adapting with the times. That's my only bit.
Thank you very much. Samuel.
Yes, so honestly, and thank you everyone for sharing along the last hour and a half. But for me, the true innovation is in the method that we take to implement solutions. Again, to what was said a little bit before, is reach out to people with diabetes, understand their pathway, and truly understand it in their complexity, country by country, and then co-building with them the solutions that they need. And not trying to copy paste things that exist elsewhere and that seem shiny in practice, but when implementing them are not as successful.
Let's use our ears twice as much as we use our mouths. Sufyan.
Exactly.
So I think echo what everyone else has said, most things we've mentioned, but just wanted to re-emphasize the importance of not forgetting the creative capital of those living with a condition and utilizing and looking at them as an ally, as a key resource, not just for co-creation, but or designing, but also delivering some of the aspects of care. Because when healthcare, I feel outnumbered certainly as a healthcare professional in terms of the burden I have to see in my clinics. But certainly looking at the avenues that people living with a condition can provide and do outside the clinic room in a constant manner, looking at that as an opportunity as well.
Thank you very much. Tim, thank you for sharing that to the group as well. So I appreciate that, your closing comments earlier. Nabuja, sorry to have taken a few minutes off your closing remarks, but got a couple of minutes left, so I'm sorry we've eaten into that. But over to you, sir, to wrap up, and thank you all.
Thank you very much. I think that we said a lot about that the treatment of diabetes is very complex, that some of integration and integration in a more effective way is really needed, but it is really necessary in the other context to obtain finally a sort of good basis for a good control of diabetes. So the technology is something that should not only be surveyed or looked for or as something that is shiny and modern, but it should be a part of the treatment, and adequate resources should be placed in order to enable that. And thank you very much. Thank you for the panelists. Thank you, and thank to all those that have devoted the time to listen for us.